Today we will be discussing about atrial fibrillation. As we know, atrial fibrillation is the most common sustained cardiac arrhythmia and it is present in about 1% of population more than 60 years of age. The incidence as well as the prevalence of atrial fibrillation increases as the age increases. And according to the Framingham data, it shows that there is a lifetime risk of 26% of developing AF in people of ages more than 40 years. By definition, atrial fibrillation is a supraventricular tachyarrhythmia and it is characterized by uncoordinated atrial activation with consequent deterioration of atrial mechanical function. There are various types of AF. We can basically divide AF into various types. Recurrent atrial fibrillation, when there are two or more than two episodes of atrial fibrillation which have been either spontaneously resolved or by drugs, they are called recurrent AF. Paroxysmal AF is wherein the episode of the atrial fibrillation resolves on its own, that is, spontaneous resolution is there. Persistent atrial fibrillation, when the atrial fibrillation episode is sustained for more than a week, that is 7 days, it is called persistent atrial fibrillation. Whereas when the atrial fibrillation episode persists for more than 1 year duration, it is called permanent AF. Lone AF is the terminology wherein usually young individual less than 60 years of age, they develop atrial fibrillation in scenario when there is no clinical or echo evidence of any cardiopulmonary disease including hypertension. So that is called lone atrial fibrillation. Whereas mechanism of atrial fibrillation, either there can be enhanced automaticity in one or more rapidly depolarizing foci in the atrium or in the superior vena cava or in the pulmonary veins, or there is re-entry in one or more of the circuits which are carrying the impulses. Foci can be there in superior pulmonary veins, right atrium or superior vena cava coronary sinus. Here we can see that this is the normal sinus node wherein the normal sinus rhythm, when there is the sinus node conducts through the AV node and then through the Purkinje system to the ventricles. When there is ectopic foci or there is re-entrant circuits, then it can lead to atrial fibrillation. Now coming to the etiology of atrial fibrillation. Atrial fibrillation can be seen in two settings. One wherein the patient is having an evidence of organic heart disease and other in patients without having heart disease. So associated with organic heart disease, the causes of atrial fibrillation can be coronary heart disease, then hypertension, valvular heart disease, cardiomyopathies can lead to atrial fibrillation, atrial septal defects, chronic congestive heart failure, WPW and myocarditis. These all conditions can cause the episode of atrial fibrillation and which is usually persistent. Now, in patients with normal heart, they also can develop atrial fibrillation because of physiologic stress. There can be pericarditis in these patients. Chest trauma can lead to development of atrial fibrillation in patients whereas heart is normal totally structurally. Then after thoracic or cardiac surgery, there can be development of atrial fibrillation. Pulmonary diseases can lead to that. Some drugs are there which precipitate atrial fibrillation. Then thyrotoxicosis can lead to AF. Also alcohol intake, fluid electrolyte imbalances, and also there can be atrial fibrillation without any obvious precipitating factor or structural disease, which is called lone atrial fibrillation. In ECG, we can see various types of atrial fibrillation. That is, atrial fibrillation is mainly characterized by fibrillatory waves, and on ECG there can be different types of fibrillation. That is, coarse fibrillatory waves can be seen, fine fibrillations can be seen, or it is associated with flutter, so it is termed as flutter fibrillation. This is the ECG. So here we can see that these are the fibrillatory waves. We don't have any specific P wave. So these fibrillatory waves are small irregular baseline undulations, and the amplitude and morphology can vary, and these are called not the P waves but the F waves. The atrial rate is typically about more than 350. It can vary between 350 to 600 beats per minute. The P waves are absent, and the ventricular rhythm, some of the conductions can get conducted, so which is erratic, so ventricular rate is irregular, and the rate varies between 100 to 160 beats per minute. This again shows the ECG of atrial fibrillation, where we can see the baseline undulations and irregular RR interval. So the heart rate, that is atrial rate, is 350 to 650. Ventricular can be slow or there can be rapid conductions, but usually it's around not more than 150-160 beats per minute. The rhythm is totally irregular. P waves are not seen. There are oscillatory waves, fibrillatory waves are seen. PR interval can't be found out, and QRS duration is less than 1.2 as seen in other supraventricular tachycardias. This again shows another ECG with rapid ventricular rate. Undulations, baseline undulations are seen. Fibrillatory waves are not very prominent because of the tachycardia, but there is irregular RR interval with QRS duration is less than 0.12. What are the outcomes of atrial fibrillation? There is loss of synchronous mechanical activity because of the erratic atrial contraction, or mainly the atria just fibrillates, it's not properly contracting even. The ventricular response to this is also irregular, and heart is rapid. So because of all these things, there is ultimately decreased hemodynamic function. There can be with time tachycardia induced atrial cardiomyopathy. Also ventricular cardiomyopathy can develop if the heart rate is more than 130 beats per minute persistently. And then because of the atrial dilatations, stagnation of the blood in the atrial chamber because of poor contractility, there can be various formation of embolus, and which can lead to thromboembolic episodes. Now coming to evaluation of a patient with atrial fibrillation. On history, we will get symptoms like shortness of breath, there can be palpitation, the patient can complain of chest pain, anginal pain, and in elderly, there's usually, very commonly, they are having complaints of fatigue. They can be associated, we can find symptoms related to underlying heart disease, features of hyperthyroidism, and history of alcohol consumption can be there. For the patients who are presenting for the first time to us and where ventricular rate is difficult to control, we send blood tests for thyroid, renal, and hepatic function. ECG will show irregular rhythm. There can be LVH if hypertensive disease or other diseases, structural heart disease are present. There can be features of pre-excitation if the AF is because of WPW syndrome or other conduction abnormalities. Bundle branch block can be there, or there can be evidence of prior MI, which can be the basic cause of this atrial fibrillation. And after ECG, we can go for transthoracic echocardiography. So herein we can see valvular heart diseases. We can see evaluate the left atrium and right atrial size, LV size and LV function. We can see evidence of LVH, and also very easily LA thrombus can be seen through TTE. After this, in some patients, exercise testing can be done. There might be need of Holter monitoring and chest X-rays for particularly seeing the pattern of atrial fibrillation and associated structural heart diseases. After the diagnosis, coming to the management, the objectives are mainly either to control the rate or the rhythm, and importantly, prevention of thromboembolic complications. So initial approach in a patient with atrial fibrillation depends on particular criteria for each individual. So in patients who are older and who have persistent atrial fibrillation, who have associated structural heart diseases or hypertension, herein we prefer rate control for the atrial fibrillation, as the rhythm control is not practically possible in these patients, especially with structural heart disease. Rhythm control is tried in younger population and in settings of paroxysmal or lone AF. First choice is drug, and if the drug therapy is not helping, then second choice is left atrial ablation, which is preferred in young patients with highly symptomatic atrial fibrillation. Those patients for coronary bypass or valve surgery, Cox-Maze-3 procedure is preferred. Coming to rate control, because asymptomatic patients with AF, rate control is sufficient. There is no need to go for or approach for rhythm control. So in asymptomatic patients with atrial fibrillation, rate control is sufficient. Also in patients with elderly patients who have usually associated other comorbid conditions and structural heart disease, rate control is the choice. So if the patient is symptomatic, he's hypertension and there is angina, heart failure, that is basically to say that the patient is hemodynamically unstable, so we directly go for DC cardioversion. But if the patient is less ill, then IV drugs are given to slow the ventricular rate. First we see the ECG. If there is no evidence of pre-excitation, then we prefer either IV beta blocker or IV non-DHPs, CCBs. But if excessive pathway is present, then we prefer either IV amiodarone or IV digoxin. In cases with persistent or permanent AF, then for maintaining the rate control, we give beta blockers, non-DHP CCBs, and in settings of heart failure or LV dysfunction, digoxin can be given for the rate control. When the drug therapy is ineffective, then we have to go for ablation of the AV node or accessory pathway. And coming to rhythm control, as a rule, patient without structural heart disease in younger population, drugs are the rhythm control is the first approach, and where there is no structural heart disease at all, propafenone and flecainide, they are the first line treatment for maintenance. If the patient is having evidence of structural heart disease, then amiodarone or sotalol are the drugs to be used. Again, if the patient is having hemodynamically compromised, he is symptomatic, hypertensive, angina is there, or the patient is in heart failure, or there is ongoing myocardial ischemia, we have to directly go for DC cardioversion. If AF is associated with pre-excitation and hemodynamic instability is there, again DC cardioversion is tried. Apart from DC cardioversion, there are various drugs which can help to cardiovert. So pharmacological cardioversion, this is most effective within the first 7 days of atrial fibrillation. The drugs used are flecainide, dofetilide, propafenone and amiodarone. Digoxin and sotalol are usually not recommended. So the patients are selected wherein there is no sinoatrial node disease or AV node disease, bundle branch block is not there, no QT prolongation, no evidence of Brugada syndrome or structural heart disease, then propafenone 600 mg or flecainide 200 to 300 mg is started. Maintenance of sinus rhythm. Once the cardioversion has been achieved, then we have to look for the precipitating causes or the causes which can be reversed, and we have to treat them. And in those patients where minimal or no heart disease is there, we can use sotalol on OPD basis. Prevention of thromboembolism. After either rhythm control and rate control, the most important thing is to prevent the thromboembolic episodes, which can be detrimental for the prognosis in patient with atrial fibrillation. So ACC AHA guidelines, they recommend antithrombotic therapy for all the patients with AF, excepting for the patients with lone AF or where there is contraindication to antithrombotic. So only in two settings, when there is lone AF, that is no structural heart disease, and when there is contraindication to antithrombotics. Except for these two conditions, in all the other patients with atrial fibrillation, we have to use antithrombotic therapy. If AF is of more than 48 hours or we don't know the duration, then anticoagulation is recommended for at least 3 weeks prior to and 4 weeks after cardioversion. So cardioversion is not tried if there is old AF or unknown duration of AF is present, because that can lead without starting anticoagulation. If we try to cardiovert, then there is chances of thromboembolism. So either electrical or pharmacological, nothing is recommended without giving anticoagulation. But if the AF is less than 48 hours old, then emergency cardioversion can be performed immediately without prior anticoagulation. The choice of therapy, the anticoagulant therapy, that depends on patient's risk of stroke and bleeding. So in higher risk factor patients, vitamin K antagonists are preferred, while in low risk patients we can give aspirin also. So the risk factors are age, hypertension, heart failure, LV dysfunction, diabetes mellitus, coronary artery disease. If more than one risk factor is present, one or more than one risk factor is present, then we should prefer vitamin K antagonist. While if in low risk patients or where there is contraindication to anticoagulation, like elderly people more than 75 years of age or history of intracerebral hemorrhage, in these patients we can use aspirin. Now coming to catheter ablation. The pulmonary veins are an important source of ectopic beads, initiating frequent paroxysms of atrial fibrillation and triggers as well as circuits for spontaneous atrial fibrillation. These pulmonary veins can be the targets of therapy. Then focal pulmonary vein isolation, linear ablation of right atrium, left atrium or biatrial ablation, circumferential pulmonary vein ablation and segmental pulmonary vein ablation. These all are the options for catheter ablation for the treatment of atrial fibrillation, those who are not responding to the pharmacological therapy. Then surgical ablations, Mage cut and sieve techniques are there. Bipolar radio frequency, cryoablation and microwave energy, all these have been used as alternatives to the cut and sieve techniques. Now a few lines about newly diagnosed AF. If it is a paroxysmal AF, then no therapy is needed unless there are significant symptoms. The patient is having hypertension or there is signs of heart failure or patient is having anginal pain, then anticoagulation is needed. And if the patient is having persistent AF, then we most likely it is going to be land up in permanent atrial fibrillation, and here anticoagulation and rate control as needed are started. Then antiarrhythmic drug therapy are sometimes considered in few patients, especially where significant structural heart disease is not there, so their cardioversion can be tried, or long-term antiarrhythmic drug therapy can be tried. And if cardioversion sustains the normal sinus rhythm, then the long-term antiarrhythmic therapy is unnecessary. If there is episode of recurrent or persistent AF, then if it is, patients are divided into those minimal or no symptoms. So in these patients, if and when indicated, only anticoagulation and rate control are started. While in disabling patients in AF, then anticoagulation and rate control, antiarrhythmic drug therapy, electrical cardioversion. In the this pattern is started, and anticoagulation is continued, and therapy to maintain the sinus rhythm also is continued, that is the AED therapy. And if it is not responding, then ablation is considered for the symptomatic recurrent AF. Permanent AF, anticoagulation and rate control as needed is preferred. Now, after achieving sinus rhythm, how the maintenance of sinus rhythm is approached. If there is no or minimal heart disease, then flecainide, propafenone or sotalol are considered, while if they are not responding, then amiodarone, dofetilide can be started, or we can try catheter ablation. In patients who are hypertension, who are having hypertension and evidence of substantial LVH, these patients we start amiodarone, and later we can try catheter ablation if it is not responding. While those patients who are not having substantial evidence of left ventricular hypertension, there we can use flecainide, propafenone or sotalol initially, and later if they are not responding, then we can